Yes. Good evening. Okay. Shall we start?
Okay. So I'm presenting a case of Mrs. XYZ, age 55-year-old woman, a resident of Daryaganj, homemaker, educated till 10th class, belonging to upper-lower socioeconomic status by modified Kuppuswamy scale 2024. The informant was the patient and her husband. The patient was right-handed and she speaks and understands in Hindi. She came with the
Okay.
presenting complaint, difficulty in
Go
walking
on, go
and
on.
imbalance for 4 years,
Go on.
weakness in the lower leg for 2 years, loss of touch sensation in feet for 1 year, slurring speech for 6 months, and slowness in the daily activities for the past 4 months. History of presenting illness. The patient was apparently well 4 years ago when the patient complained of imbalance or unsteadiness while walking, leading to multiple fallings that was like a drunken person. She was having a slow, wide based gait with swaying on either side as well as to the back. There's no history of pain associated with walking or shortness of limb, no history of being glued to the floor or short step gait or high step gait, stamping or slapping gait or dragging gait. There's no history of dizziness, lightheadedness, vertigo, nausea, vomiting, decreased perception of movement, or worsening of ataxia on washing of face or closure of eyes. No history of tremors when reaching for objects. No history of overshooting acts. No history suggestive of involuntary rhythmic oscillation of the eyes. 2 years ago, she found difficulty in gripping chappals, but there was no difficulty in the slipping chappals out. The patient also complained of inward bending of the foot when initiating walking for the past 1.5 years, causing her to trip and fall. 1 year ago, she was finding difficulty in rising from the squatting position. To get up from the squatting position, she first used her upper limbs and trunk muscles for support and then got up. She also complained of bilateral thinning of calf muscles for the past 7 months associated with fasciculations. She is currently bedridden, unable to walk for the past 6 months. She is able to roll over in bed. She is able to raise her head from the pillow without support. There is no difficulty in buttoning and unbuttoning shirt, eating food, or combing hairs. 1 year ago, she also complained of her being unable to differentiate whether she is having a chappal on her feet, walking barefoot on the floor. She couldn't appreciate hot water from
Okay.
cold
Go
water
on.
while taking bath. She
Go
wasn't
on.
able to feel pain from insect bites on her feet. No history of tingling sensations or burning pain in the limbs. The patient complained of slow and slurred speech for the past 6 months. The patient felt that there was an undue separation of syllables while speaking. There's no history of thinning of the tongue muscles or fasciculations of the tongue. The comprehension, fluency, and repetition were not affected. No history of facial deviation or inability to close eyelids or drooling of saliva from mouth or loss of taste sensation. No history of dysphagia, nasal regurgitation, hoarseness of voice, or nasal intonation of speech. The patient complained of slowness in initiating, continuing, and ending movements for the past 4 months. She told that it is taking her more time to do everyday tasks like sewing, dressing, and bathing. There's no history of resting tremors, mask like face, stiffness of limbs, stooped posture, reduced eye blink, or shuffling gait. No history of restless legs, insomnia, daytime somnolence. No history suggestive of dementia, anxiety, depression, apathy, or psychosis. No history of abnormal sweating, urinary retention or incontinence, constipation, dizziness on standing. No history of frozen shoulder, periarthritis or swan neck deformity. No history of pain or reduced sense of smell. No history of cold intolerance, fatigue, weight gain, constipation, or menstrual changes before the onset of disease. There's no history of any lump anywhere in the body. No history of altered state of consciousness or difficulty to recognize people or objects or inappropriate crying or laughing or lack of interest or social disinhibition or history suggestive of delusions or hallucinations. No history of loss of color vision, smell, double vision. No history of alteration in facial feeling or problem in chewing. No history of any hearing abnormality, no history of any involuntary movements. Past history. There are no similar complaints in the past. No history suggestive of seizures, heart disease, asthma, COPD, diabetes, hypertension, TB or TB contacts, hypo or hyperthyroidism, STI or chronic drug use. No history of previous hospitalization. No history of any trauma or surgery. Personal history, she eats a mixed diet. Appetite is normal, no food allergies. Bowel and bladder habits are normal. Sleep is enough and adequate. Sleep-wake cycle is not altered. No history suggestive of any high-risk behavior. No history of loss of weight over the past 6 months. No history of smoking, tobacco, alcohol, or any other substance abuse. No chronic drug use or any medication at present. Family history. One brother had a drunken gait beginning at 48 years and is unable to walk for 2 years. Two sisters developed similar complaints of imbalance, multiple fallings, weakness in the lower limbs, and inward bending of the feet at around the same age, 50 years. There's no history of TB, diabetes mellitus, hypertension, epilepsy in the family. Her father died around the age of 50 due to alcoholic liver disease. Dietary history. Total calorie intake per day is 960 kilocalories per day. Total protein intake per day is 16 grams. Calorie deficit is 23%. And the diet is deficient in fruits, nuts, and seeds. Menstrual and obstetric history was not significant. Summary. Mrs. XYZ, 55-year-old lady, resident of Daryaganj, homemaker, educated till 10th class with no known comorbidities, presented with complaint of difficulty in walking and imbalance for the past 4 years, with swaying to either side and to the back. She also presented with lower limb weakness for 2 years, which was insidious in onset, gradually progressive in nature, started from bilateral distal lower limb to bilateral proximal lower limbs, associated with inward bending of the foot and calf atrophy. For 1 year, she is having numbness in bilateral feet, complain of slurring of speech for the past 6 months with no history of cranial nerve involvement, history of bradykinesia for the past 4 months. Similar complaints present in her siblings at the same age, no signs of autonomic dysfunction or symptoms of meningeal irritation.
Okay, so that's a very good history, very elaborate and very good history for undergraduate students. That is very wonderful.
Thank you.
So we will look at this visualization point of view, like what is needed at your level. We'll start. So this person's problem is a gait disorder, and you have clear is to start with. It's a gait problem, and you have clearly mentioned there is no short limb, there is no limbing. That's all wonderful. I should appreciate like anything the way you have presented. You see, a gait disorder is categorized into two things. Grossly, a person can have a gait disorder due to executory apparatus defect. That you seem to know, that you have clearly told. The executory apparatus is the joints, muscles, ligaments, tendons. They are the end executory apparatus for walking. Whereas central modulators are basal ganglia, cerebellum, corticospinal tract, as well as cognition. So it is the primary coordinators of gait. So you have clearly told there is no limbing, there is no short limb. So it is probably not due to a executory apparatus defect where you find limbing gait, short limb gait, or you may have high stepping gait, you may have a buckling gait. But something happened in between which came later in the course of the disease, which looks like probably an additional executory apparatus disorder is there. But primarily to start with, it was not. And so this person was swaying to either side with a broad base. So as we you can have so many higher organs involved, which can contribute to a gait disorder. So we categorize that when we describe as first we will be standing. First before we walk, we stand. And when we stand, for stable standing without swaying to either side, normally that is called a stance, S-T-A-N-C. So stance is the distance covered between 2 feet for stable standing. In a normal person, it is usually about 9 to 12 inches. That will be equal to 1 foot, or if it is a child. So this is an adult person. If it's a child, you can use their own feet. So stable standing without any absolute measurement will be age, gender, height, matched tables are there. So for this much tall person, this many years old person, this much weight, that should be the stance. There are normalization data But otherwise, grossly, you can say that for any age group, 1 foot distance of their own feet. Yeah, 1-year-old child means 1-year-old child's feet. You keep it in between both feet. That will be sufficient for the child's stable standing. And for an adult, it is our own feet in between both feet. So that is normal stance. At the bedside, we are not going to use a gaiter. So we will say if 1 feet distance in between is okay, without any wobbling, that is stable. You said this person has got a broad base. That means you are trying to convey that my patient needs to keep the feet separated more than 1 foot of his own feet. At the bedside, that is how we calculate. So 1 foot of the own patient will not give him stability. So he has to separate it widely. So what are the situations where you get this broad base? So that is what first you told, broad base gait. You want to tell? You have got a very good history, wonderful history. So tell.
Cerebellar disorder, then
Very good.
the dorsal column pathway, that is the visuospinal pathway. Then the vestibular apparatus. These three cases we get.
Among this, cerebellum is broad-based, vestibular is broad-based. Sometimes even in the lower motor neuron, if you have adductor weakness, some muscle diseases, sarcoglycanopathies, their adductors become weak. So they keep the feet widely separated, abducted. So it can be cerebellum, or it can be vestibular apparatus, or it can be due to adductor weakness with respect to the proprioceptive pathway, which you said. Generally, this kind of criteria will not be very clear. If you really see a patient with sensory ataxia, probably commonly you may see diabetic neuropathies with severe sensory deprivation. They are very bizarre because it is at every movement their gait becomes abnormal. When they stand, it is not wide base. What is more obvious when they stand will be, they will stand with their eyes fixed on the feet. So visuospinal reflexes abnormal means patient is not getting a proprioceptive input regarding where is their feet. They have no problem in adjusting their feet with the center of gravity through the center of the spine. Their problem is they don't know where is their feet. So they feel very insecure. So they will fix their eyes on the feet. Then they are stable. Otherwise, what they do is, they will be trying to explore the floor to ascertain their relationship with the floor. That is called dance detendant. It is not exactly broad base. They will be exploring the floor with their toes, like this kind of movements. Next time when you see an advanced diabetic neuropathy, you just observe. When they look at their feet, vision is telling them where is their feet. Otherwise, they don't know. So either they stand with their eyes fixed on the feet, or the eyes are not fixed for some reason. You tell the patient, look straight, sir. Then what they will do is, they will explore the floor with the toes. That is called dance detendance. With the tendon, they constantly try to explore. Because they don't get the information, they keep on moving the tendon of toes. That is what you find in sensory deprivation. So that a broad base is there. So either vestibular dysfunction or cerebellar dysfunction, or my patient has got a adductor weakness. That is what you will consider at this point. Then you said that your patient is swaying to either side. So, and sometimes backwards, you told, no? So swaying to either side, would you like to elaborate what all situations? You seem to be very good in neurology, so it's a very wonderful presentation. I really appreciate. So you just answer. You seem
Wordness of the cerebellum could be involved.
Very good. So which part of the cerebellum will involve? Because you clearly told At that time, there is no oscillatory movement of the eyes. There was no problem in bringing the fingers to the mouth. All those things you said. So which
Yes.
all parts of the cerebellum will affect only gait? At that point, 4 years ago, if you have seen,
Paliocerebellum.
so very good. That is what part of the cerebellum, what part of the cerebellum is called
Anterior.
anterior. You have got a great horizontal fissure. Great horizontal fissure is there. And the region of the cerebellum in front of the great horizontal fissure is paliocerebellum. So,
Yes.
so that part contains what all part of the body represented?
The
We
whole
tell something
paliocerebellum.
called homunculus. You heard of homunculus in your anatomy, no? How is
Yes.
your body represented in various parts of the nervous system is called homunculus. So cerebellum also has a homunculus. So anterior part, paliocerebellum has got which part of the body represented?
The vermis will have the truncal part, and the lateral hemispheres will have the limbs.
You see, it is called as three-monkey homunculus. You heard cerebellar homunculus is called three-monkey homunculus. So what happens is you have got two monkeys lying on their sides.
Yes.
And one monkey lying supine. All the three monkeys' trunk is in the vermis. The midline of the cerebellum is called vermis. I'm sure you know that. The midline of the cerebellum is called vermis. All the three monkeys' trunk is in the vermis. And paliocerebellum contains the legs alone of the monkey which is lying supine. Only the legs. That is why paliocerebellum produces gait ataxia. So only the legs of the supine monkey is lying in the paliocerebellum. Whereas all the trunk is in the vermis. And upper limbs and eyes and mouth is in the neocerebellum.
Yes.
You see? Whereas the legs of the side-lying monkeys, it is like this. One monkey is like that with the legs, and that leg is in the paliocerebellum. The trunk of all the three monkeys in the vermis. And these two monkeys which are side-lying, they keep their trunk in the vermis. The head and neck and upper limbs go into the neocerebellum. It is like this, neocerebellum. And then the legs of these side-lying monkeys are coming to the archicerebellum. Archicerebellum is flocculonodular lobe. That is the posterior part of the cerebellum. Anterior part is paliocerebellum, mid part is vermis, and mid-lateral zones are neocerebellum, and posterior part is archicerebellum. That archicerebellum contains the legs of the side-lying monkeys. So, gait abnormality, in which part of the cerebellum you will expect? Now, you the common thing.
Flocculonodular lobe and paliocerebellum.
Yes, either in the paliocerebellum or flocculonodular lobe. These are the two locations. In the cerebellum, you will get gait ataxia alone. So how to differentiate these two? I told that in the paliocerebellum, only leg is there and nothing else is there. Upper limb is not there, eyes are not there, so nothing will come. Whereas in the flocculonodular lobe, you see the nucleus of the flocculonodular lobe is vestigial nucleus. It is a vestibular system. So vestibular system is connected to the flocculonodular lobe. So gait will be also guided by the vestibular system in the flocculonodular lobe. That will give its character. So paliocerebellum will produce just gentle swaying to either side with a broad base is paliocerebellum. There is nothing else. And the nucleus of the paliocerebellum is emboliformous. Whereas flocculonodular lobe nucleus is vestigial nucleus. Vestigial nucleus is governing the vestibular system. So vestibular system produces severe swaying. Unlike the cerebellum, vestibular system produces severe swaying. So because of its connection to the vestibular system, flocculonodular lobe will produce a wide arc sway. Wide arc, the classical cinema picture of a drunken person swaying through a very wide arc, going to either side in a very wide arc is flocculonodular lobe because it is linked to the vestibular system. Second, vestibular system controls the eye movements also. So patient will get a nystagmus. So if the flocculonodular lobe is affected, a wide arc gait, reeling gait, we call it as a reeling gait. Whereas paleo-cerebellar gait is called swaying, gentle swaying to either side. Flocculonodular lobe is a reeling gait and they will have nystagmus. And the nystagmus will be of vestibular character. That much elaborate eye movement control, maybe you need not know. The vestibular nystagmus will be horizontal and rotary. If you just want to remember, it will be horizontal and rotary nystagmus. So flocculonodular lobe is wide arc with a horizontal rotary nystagmus, which is not there in your patient. So probably your patient's problem started with the paleo-cerebellar involvement. So any other system, the connections of the cerebellum. So is it the connection of the cerebellum that is involved? That question is next connection. Cerebellum itself is paleo-cerebellum, neocerebellum, vermis, and flocculonodular lobe. Vermis will produce truncal ataxia because all the trunk structures are there, so trunk will wobble. When the patient walks also, the legs will not sway. The trunk will sway like that. That is vermis with the head nodding. Neocerebellum, I told that the upper limbs and eyes are there. Mouth is there. Head is there. So speech, cerebellar type of nystagmus. That is gaze evoke nystagmus. You look to the right, the nystagmus will be faster to the right side. Look to the left, nystagmus will be faster to the left side. Look up, it will be faster to the up. That is the classical cerebellar nystagmus. That will not have a rotary component. And speech, because the head and neck is in the neocerebellum. So they will have nystagmus, dysarthria, and upper limb incoordination. Is it clear now? So
Yes.
parietal cerebellum is swaying with no other company. Neocerebellum is cerebellar type of nystagmus, that is gaze evoke nystagmus, dysarthria, and upper limb incoordination. Whereas flocculonodular lobe is reeling gait with the vestibular type of nystagmus. So next we will see whether it is paleo-cerebellum or it is the connections of the cerebellum that is involved. You know the connections are superior cerebellar peduncle,
Cerebellar peduncle, middle
cerebellar
cerebellar
peduncle,
peduncle, and
inferior
inferior
cerebellar peduncle. So whether the peduncles are affected, we can try to analyze. Because that will point you a different cause. Which structure is affected tells you which is the etiology of your patient's problem. So if it is superior cerebellar peduncle, what will be the feature? It contains
dentatorubro-thalamo.
Very good. Wonderful. Wonderful. It contains the dentatorubro-thalamo-cortical pathway. So this mainly contains cuneo-cerebellar fibers, the fibers which come from the upper limb. So dentatorubral pathway mainly carry cuneo-cerebellar fibers. So peduncles, one point you can remember, peduncles never produce dysarthria. Peduncles never produce cerebellar type of nystagmus. So if that is gaze evoke nystagmus is there or dysarthria there, it is not a peduncle. You don't have to consider a peduncle at all. And superior cerebellar peduncle, because the upper limb fibers are there, it will carry upper limb incoordination of dentate nucleus type or the red nucleus type. Dentate nucleus type will be intention tremor. Red nucleus type will be horizontal action tremor. It is like this. You put the patient's hands like this, horizontal action tremor is red nucleus, whereas dentate will be intention tremor. That is superior cerebellar peduncle. So it is not your patient's case. He is having only a gait problem. So yeah, what about the middle cerebellar peduncle? Can it be causing the gait disorder? Would you like to tell? You are answering very well. Wonderful. You become a neurologist. Yes, neurology is mathematical, philosophical, and spiritual. Unlike other subjects, I think any good neurologist at one point of time becomes spiritual because you will understand the beauty of creation in the nervous system only. No? So what is middle cerebellar peduncle?
Cortico-pontocerebellar pathway.
Wonderful. So what is the unique feature about that?
Coordination, the planning cycle.
So unique feature of the middle cerebellar peduncle is this is the only area where the corticocerebellar and spinal, that is the pyramidal tract. The pyramidal tract and the corticocerebellar tracts are traveling together. This is the only side. Otherwise, your cerebellum will produce ipsilateral features and corticospinal tract will produce contralateral features. So middle cerebellar peduncle contains the cortico-pondocerebellar fibers, which is a combination of pyramidal fibers and the corticocerebellar fibers. So middle cerebellar peduncle will produce gait ataxia, but it will be spastic ataxia because of the corticospinal tract is also traveling. So if the patient has been swaying as well as he felt the leg is stiff and is dragging. So swaying patient who feels stiff and he drags, that is middle cerebellar peduncle. From the history, our patient was not stiff, not dragging. So it is not middle cerebellar peduncle. So I just, more than the diagnosis, anatomy localization is very important for small boys and girls. So you can build your theory on that. That's why I am discussing at this level. No? Next is the inferior cerebellar peduncle. Very characteristic only. Inferior cerebellar peduncle contains the fibers which are going into the flocculonodular lobe. That is vestibulocerebellar. Yes. So they will produce vertigo, nystagmus and a reeling gait which very much resembles a flocculonodular lobe. So inferior cerebellar peduncle will look like a flocculonodular lobe. So apparently it is fitting only into probably paleocerebellum. The history from your patient is a gentle swaying with none of the unique features of its connections. So probably it is only a paleocerebellum with the, if the history is correct. Because it happened 4 years ago, how much she is remembering and recalling is also important. So if she has really told you with the proper memory, this looks like a starting from the paleocerebellum. So at this point, for completion, because you insisted on the sensory ataxia. So how will be the sensory ataxia? Stance. Stance will be, we just discussed. So patient will be,
Stamping gait will be present.
very good.
It will be gaze, like she will have to put her vision on her feet while walking,
Very good.
or it would be dance tendon movement that she would
Very
have
good.
to like
Yes.
if she is told to look forward, then she would be assessing the depth from her foot.
Very good. That is the stamping you told. You see, the moment you remove your eyes and you start walking, you do not know how much you have to lift your foot to reach the floor correctly. Because they don't know where it constantly our brain is told where your body is. That is called positive cortical tropism. Body is continuously sending information to the homunculus. Here is your hand, here is your leg. So the brain is adjusting your body position. So when there is a proprioceptive loss, brain does not know where is your leg and where is the floor. So the patient will lift the foot much higher and bring it down not knowing where is the floor. That causes the stamp. Lifting very high and bringing down with a thud. That is the stamp. So then patient will realize somehow I am not understanding the depth. So let me carry a stick. So they will carry a stick and try to assess the depth of the floor by hitting with a stick. But then they will think, okay, this much depth only, I know where is the floor. And but the moment the stick is removed and the noise from the stick is removed, they don't know the floor. So usually it is called stick and the stamp gait. So they carry a stick, hit the floor with a stick, but the moment the stick is removed, they fool themselves, they don't know. So they again lift their feet very high and bring it down with a thud. So that is the classical sensory gait, stick and the stamp gait. And if you forbid them from looking at their feet other things throughout the range of the gait, it will be very bizarre. Because every part of their movement, they don't know where is their leg. So they will put it in a very bizarre pattern. Sometimes we may think it is psychological gait. It will not fit into a spastic gait. It will not fit into a muscle disease gait. It will not fit into a cerebellar gait. Why are they doing like this? Why is he doing all this dancing phenomena? We'll think very bizarre. They will move here, there, and they will act severely falling in a very bizarre way, not swaying and falling. So that is typically sensory gait, and that will worsen in the dark because the vision is removed. And when they wash their face, I am sure you know it's a wash basin sign. So sensory gait is a gait where the patient has to fix his gaze, or if removed dance tendon, bizarre lifting movements, stick and the stamp gait, which is worse at night and worse during vision removed due to any cause. So that is the sensory ataxia. Then ataxia mimic, as I said, adductor weakness or abductor weakness, waddling gait. A person who waddles due to muscle disease, they don't know that cerebellum produces swaying and abductor muscle produces Trendelenburg effect. So they will say, I am swaying. So if you don't really ask what you mean by swaying, swaying means the whole body. That has to move like that. That is swaying. Whereas waddling is at the level of the pelvis. That also they will, patients generally tell they are swaying. So that also you should remember. Some chronic peripheral neuropathies, muscle diseases, they also tell they are swaying. So these are the various situations where the gait becomes altered. As you told the executor apparatus, you will discuss. Then you will tell stance, pace, turns. So stance is the distance covered between both feet for stable standing, wide or narrow. Narrow happens in frontal lobe, basal ganglia disorders, etc. Then pace is the distance covered between 2 feet for stable walking. After you stand, you start walking. So distance covered between 2 feet for stable walking is called pace. So that pace is how much? Pace is also larger in cerebellar. So you have to describe the gait like that, stance, pace. Then turns. Mild degree of imbalance will be most obvious when the person tries to quickly turn. Routine walking, he may be all right. When he tries to turn, they wobble. So pace, stance, pace, turns. Then you have to describe it as anti-gravity stretching, stepping, propulsion, equilibrium. So anti-gravity stretch means you are standing with your stance. After that, how are you going to move forward? You have to oppose the gravity and lift your feet. So that is anti-gravity stretching. So are you able to?
Photo.
Very good. Wonderful. Very good. So how are you able to clear? You have described that comes with a heel strike. Very good. So is he able to clear the gravity's pull and lift the foot? So stance, after stance, anti-gravity stretch. Then stepping. Stepping is how much distance, that is a pace. Then you have got, after you start, after you have cleared the gravity's pull, you start walking. Then there is something called stepping that you are showing in this picture. One leg is flexed, the other one has to extend. That is called stepping. If both legs flex and both legs extend together, you will be like a log of wood at one point and you will fall down at the next point. So this coordination is done by locomotor center. So one leg is flexing, other leg is extending. This goes on alternating. That is called stepping. So is the patient stepping properly? If he is not able to step, it is a pyramidal disease. Spastic weakness, spastic paraplegia, or any spastic weakness, stepping will not be there. So anti-gravity clearance, is it all right? That is something called gait apraxia or ignis start hesitation in Parkinsonism. So in frontal lobe disorders and Parkinson's disease, you will have anti-gravity structure difficult. After that, Stepping becomes altered in pyramidal disease. Then if the stepping is all right, then you move forward. That is the propulsion part. So when you propels, how much is the distance between 2 feet? Are you having stamping, stepping, high stepping? Are you have some problems later in your patient? The feet is inverting, you said. So something like that. So all these phenomena during propulsion. Is it the toe first or the heel first? Normally it is the heel strike first. So is the heel striking or the toe? If there is a foot drop, then it will not be the heel strike. It will be a toe first. If there is a tendo Achilles contracture, it will be toe first. If there is a dystonia, it will be toe first. If there is a pyramidal disease, it will be toe first. So is it in the propulsion part, see whether it is heel strike or the toe strike. What is the distance between 2 feet? And is the person high stepping? Is he stamping? Is he tending to invert, any involuntary movements, any buckling? All these are swaying, reeling, all this in the propulsion. Then, and equilibrium. So, anti-gravity structure, stepping, equilibrium, propulsion. So, this is how you will describe the gait of a person when you examine. Anti-gravity structure, stepping, equilibrium, propulsion. So apparently in your patient, from the history, only the third component is affected, the equilibrium component. Anti-gravity stretch is apparently all right. Stepping is apparently all right. Equilibrium is affected. And that way propulsion is affected by sway. Because the equilibrium is affected, propulsion is also affected. That is what is happening in your patient. So that is grossly the gross cerebellar localization. And for your level, people ask, tell all the cerebellar signs. Would you like to tell?
Yes,
No,
ma'am.
I'm sure you know.
So
Start
starting from
with
gait,
Hmm.
okay, height. Okay, so we can start from nystagmus, which is
Yes,
usually gait evoked nystagmus.
very good.
But as you told that in flocculonodular lobe, it would also be horizontal nystagmus and rotatory nystagmus.
Hmm.
Then there will be dysarthria. So there are two types, scanning and staccato speech.
Very good.
Scanning would be where there would be elongation of the word that would be spoken
Splitting of
and
the syllables. Splitting of the syllables.
splitting of the
Scan
syllables.
means you cut it into pieces. Scan. So it is splitting of the syllables. Okay.
And in staccato, some vowels or some sounds would be high pitched and the other would be in normal.
Explosive
Explode.
character. Suddenly it explodes where you don't have to stress. We generally stress and explode when we are stressing on a point. Whereas a staccato speech patient will become suddenly explosive, which has nothing to do with the meaning that is conveyed. That is staccato speech. Then?
Then intentional tremors would be present, that wherever the patient would be trying to reach for an object, then the tremor would start. Um, then overshooting would be present. Then rebound
Overshoot
phenomenon.
or undershoot, both.
Okay, that is dysmetria would be present.
Hmm.
And then past pointing at all that comes in that. Then dysdiadochokinesia would be present. That is inability to rapidly perform alternating movements. Um, then gait would be affected,
Rebound
which would
phenomena, you want to tell? Rebound
yes,
phenomena?
ma'am. Rebound phenomenon would be that when the patient would be like asked to hold his hands in front and we would leave them, then they would come down, they would fall suddenly. So means they would the stopping of the movement would not be present.
What is that? See,
A
normally
rebound.
in any motor command, agonist is initiating the movement, antagonistic is keeping quiet. Whereas in the motor plan, there is something called motor plan. Body has a motor plan. At the end of the movement, antagonist become activated. So you stop the movement. So when you start, it is the agonist. At the end, it is the antagonist. This antagonist activation fails due to connections from the emboliformous nucleus. So antagonist will not act and stop the movement. So it goes on. That is rebound phenomenon. Okay. Yeah.
Then,
Good.
ma'am, gait would be. Titubation is also present. Titubation is the head bobbing and the neck and the head bobbing would be present, involuntary.
Very good. Then truncal ataxia, you can say.
Yes, ma'am. Truncal
And
ataxia.
lower limbs. Lower
Hypotonia would be present.
Gait ataxia, reeling, swaying, pendular knee jerk,
Yes, ma'am.
and
Pendular knee.
depressed reflexes. Not always, but reflexes can be depressed or normal.
Okay.
So that is cerebellar signs, all the signs you have enumerated, and we have localized except the vermis. In the vermis, you will have titubation, truncal ataxia, and posterior vermis has got some emotional connection. So patients with cerebellar disease can be depressed, panicky, that and all is due to posterior vermis and its connection to the limbic system. So that is very nice. So first symptom appears to be paleocerebellar. Very good. Very nice. So this is the functional ratio. You have got the vestibulocerebellum, spinocerebellum, neocerebellum. Wonderful. You have done good homework. That is very nice. Okay. Go on. This is what we just now discussed.
Yes. Then this weakness history.
Yes. So next you told difficulty in gripping chappal, but there
Yes.
was no sleeping out. So you have got many things in gripping. One is gripping with awareness, gripping without awareness. So gripping without awareness is sensory, and gripping with awareness is motor, and putting on, gripping and removing is kinetic melody. That is the rhythm of motor activity. That is pyramidal. If you want to put in your chappal, hold on and walk and remove your feet comfortably, you have to activate your agonist muscle, inhibit your antagonist, and facilitate your synergist and fixator. These are the 4 groups of actions that take place in any motor activity. Agonist does it, antagonist inhibit, synergist and fixator support. So these are very carefully graded. If that careful grading is not taking place, when you try to insert your feet into your chappal, some toes will come near, some toes will separate. So patient will have to separate the toes which are coming to override. So in putting into the chappal will be difficult. Gripping on and walking is also difficult because again the kinetic melody is not there. And when you remove also, some of the toes will come because antagonist may be activated when agonist should be activated. So all the 3 phases, putting on the chappal, holding on and walking, and removing the chappal, all 3 are weak, means it is upper motor neuron. Supposing you are able to put on the chappal easily, because the toes are separated in small muscle wasting or weakness. But you are not able to grip and walk because you cannot hold on, and you remove very easily. That is lower motor neuron, small muscles. Upper motor neuron, all 3 will be affected. Lower motor neuron, putting on will be easy because the space is more in between the toes. When the small muscles are wasted, the toes remain separated. So you can put it easily, but you cannot bring it together to hold on. You can remove easily. That is lower motor neuron. Whereas you can put on while you look at the feet. You can hold on and walk when you look at the feet, and you can go on walking with you look at the feet. Otherwise, you cannot put on without looking, and the chappals will slip off without knowing. You will have moved a few steps forward and your chappal will be lying behind. That is sensory. So here you are no slipping off of chappals, but difficulty in gripping. So this
Low
gripping,
motor neuron.
maybe the patient has got a mild weakness. If it is severe weakness, it will slip off. But slipping off will be with knowledge. Here it is not slipping off. He has difficulty in gripping and walking. That means mild distal weakness of the intra-ossei. Mild weakness of the intra-ossei is the only thing which will produce difficulty in gripping, but there is no slipping off. So apparently, because all three phases are not involved, the next localization may be small muscles. Or the muscles may be involved at the level of the peripheral nerve, or it may be muscle itself. We do not know what is the nature of the disease. We will try to evaluate later. So it looks like, because sensations are at this point not affected, so probably it is the intra-ossei muscles, that is plantar intra-ossei. Plantar intra-ossei are adductors. When the plantar intra-ossei are affected, the toes will not adduct, so you cannot grip. So looks like that. At what level? If it is at the nerve level, you will find that sensation is also affected. Then only you can think of nerves. If it is purely motor, it may be muscles or nerves. Both may be motor nerves. You have got nerves having motor fibers, sensory fibers, and autonomic fibers. Various diseases can sometimes affect everything, or some diseases select either the motor fiber or the sensory fiber or autonomic fiber. So at this point of time, it is motor. Whether it is at the level of the muscle or the nerve, we will need more information and then only we will decide. So that is the thing. Then inward bending of the foot. So inward bending means inversion. So your feet is inverting. So the patient's feet is inverting. What are all the invertors muscles? Do you know the muscles that invert? The feet is inverting means the inverting muscles are strong. So what are all the inverting muscles? Tibialis anterior, tibialis posterior. Tibialis anterior will invert a dorsiflex foot, whereas tibialis posterior is in the plantar aspect. It will invert a plantar flex foot. So tibialis anterior is dorsiflexion and inversion. Tibialis posterior is plantar flexion and inversion. So if the foot is inverting, irrespective of whether the angle is dorsiflexed or plantar flexed, you will consider both the tibialis are strong. Tibialis anterior and tibialis posterior are probably strong. That is why irrespective of whether your angle is dorsiflexed or plantar flexed, it is inverting. So inverters are stronger than the everters. That is why it is inverting. So who are the everters? Peroneus longus, peroneus brevis, peroneus tertius. So in your patient, probably the lateral compartment muscles are becoming weaker. Initially, the weakness started in the intra-ossei muscle, and now probably there is a disproportionate weakness involving the lateral compartment, that is peroneus longus, brevis, and tertius, and tibialis anterior and posterior stronger. So the leg is being pulled in the plane of the stronger muscle. So the next group of muscles that seem to be involved is lateral group of leg muscles. So that is the next one. So next, initiate walking for bending of the O. So when he tries to walk, it is inverting. Understood. Is there any foot drop? Is the toes coming?
On examination, there was a foot drop, but like on history, I couldn't get it.
That is true, because she is not a very, may not be very observant, and now she is bedbound, and she will definitely not be able to explain how was her gait cycle in the beginning of her disease. That is understandable, but whatever history we have got from that, we will try to analyze. That's all, no? Maybe she had a foot drop also, we don't know, but now it is not, history it is not there. So find difficulty in rising from the squatting position. And she first used her upper limbs and tongue for support and then got up. So what is that you think? Rising from the squatting position involves many steps.
Proximal muscles,
Yes,
the gluteus maximus.
agreed. Very good. So gluteus maximus extends the hip. Then what else? To get up,
Uh,
what other
there
things
will
to extend?
extensors of the knee, that is
Very
the
good.
quadriceps femoris,
Very good. Then
the
dorsiflexors of the angle.
dorsiflexor.
Then erector spinae, paraspinal muscles. So for getting up from the sitting posture, you need agonist muscles as dorsiflexors of the ankle, extensors of the knee, extensor of the hip, and extensor of the spine. These are the agonists. The opposite group is the antagonist. So if there is a problem of the spine extensor, what will happen? If your disease is in the spine extensor, now which
She'll not be
groups
able to
involved? Yes, that's a
sit
small
erect.
muscle on the lateral compartment. Next is it the spine extensor. What will happen?
She'll not be able to sit erectly.
Very good. She will not be able to sit erect and she will not be able to support her trunk on her legs. So generally, person with a spine muscle weakness, they will not be able to turn in their bed. They cannot get up from the sitting posture without support. So they will sit, but they cannot erect their spine and get up. So somebody will have to pull them. Then they will stand because the hip extensor and the knee extensor are normal means they will stand. They will stand with a bent spine. Spine extensor weak means they become bent like that. So that is spine extensor. If the hip extensor is weak, what will happen? If the hip extensor is weak and spine extensor is normal, that is
She'll
the
not be able to get up from the squatting position.
yes. So from the squatting position to get up, hip extensors cannot be used because gluteus maximus is weak. So what they will do is that is called a trick movement. So spine extensors have an origin from the iliac crest. So spine extensors are also having attachment to the lateral part of the spine from the transverse process and the lamina as well as the iliac crest. So the iliac crest part is capable of lifting the legs. It acts as a synergist during getting up. Gluteus maximus is the primary hip extensor, whereas erector spinae is a synergist. So gluteus is not working. Okay, I will use the synergist. So what the body will do, ask the erector spinae, this person is not able to lift the leg. Why don't you help? So the erector spinae's attachment to the iliac crest. From there, it will pull the leg. So if it has to pull the leg, it cannot erect the spine. Because supposing now you are in this session, you cannot be in another session in your college. You can be in one session only. So like that, the erector spinae is pulling from the iliac crest means it cannot keep the function from the lamina and the transverse process alive. So the spine will bend. So patient will flex the spine and pull the hip up. So typical muscle disease patients get up like that, the Gower sign. The Gower sign is because erector spinae is pulling the iliac crest to lift up the patient. So it has to give up erecting the spine. So the hip will go up. That is called hip up sign. And after the hip has gone up, we can never imitate. A person with a normal erector spinae cannot imitate this movement. So after lifting the hip up, patient will try to stabilize his legs with the quadriceps and the cruciate ligaments of the joints. So for that, slowly they will put one hand. Both hands will be on the floor at that time when the hip is up. Then put one hand on one leg and stabilize their knee. So at that point, they are standing on two legs and one hand. That is called tripod sign. Two legs and one hand. That's called tripod sign. After that, slowly they will fix that knee with the cruciate ligament and the quadriceps and lift the opposite hand and put it on that knee. Then slowly climb and release the erector spinae from the iliac crest. That is the climbing up, the typical climbing up. Slowly release. That way you can stand. You need only quadriceps and the cruciate ligaments and the erector spinae to stand. So that is the classical Gower sign. So hip will go up, patient will stand on tripod, then slowly climb, stabilizing the knee, and then erect and release the erector spinae from the gluteus. So if it is a gluteus maximus weakness, you get the typical Gower sign. So that is what. So was this patient having any of these? Is the person able to explain? May not be, she will be. But just we will just go through the exercise. In a person who is able to explain, we can localize. And if the person has got knee extensor weakness, then patient will sit straight. Patient will lift the pelvis. But when the patient tries to stabilize the femur on the tibia, they will buckle and fall. Because the quadriceps prevents the buckling. So the initial part of the getting up will be all right. But when they try to stand, they will buckle. That is quadriceps. Then dorsiflexors of the angle, if they are weak, when they try to put their weight on the angle and getting weight on the feet and getting up, angle is unstable. So they get up comfortably, but they will, in the initial phase, they will fix their angle from wobbling with their hands. That's all. Otherwise, the semiology of the gait will be normal. So what was the difficulty in our patient? We do not know. The typical picture, definitely no patient can explain unless you see it.
Like the Gower sign only that you explained.
So in that case, she might have developed the proximal muscle weakness also. Slowly from the distal muscles, she is leg muscles, then the hip muscles are probably getting affected slowly. So that is possible. Then she currently, so now she's developing thinning and wasting. Why do you say use the word thinning?
Mom, she was saying that they have gone thin, the calf
So
muscle.
generally, the word thinning is for muscle weakness which happens during fever or systemic disease. When you become thin but your power is not altered.
Okay.
Whereas this person's power is altered. So it's wasting.
Okay.
Wasting is, your power is, wasting is pathological. Thinning is not pathological. You see, when you have fever or when you have take your vardams for long period, you become thin, but you don't become wasted. Wasted means power is also lost and bulk is also lost. Power plus bulk is wasting. That is always abnormal. Either nerve disease or muscle disease like that. Whereas thinning is secondary to reduce nutritional intake. So this is wasting rather than thinning. Okay. Then she is currently bedridden, unable to walk for the first. So at this point of time, my patient has got a probably a cerebellar involvement plus lower motor neuron involvement together has happened from this history. She is able to roll. Okay. The next. So it's a combination cerebellum plus probably lower motor neuron. Okay. Being unable to differentiate, she's having chapel. So now she's developing some sensory features, no? Whether she's having chapel in the feet. So initially to start with, it was motor. Now
Yes.
she's getting sensory involvement also. Okay. Then she could not appreciate hot water from cold water. So it is both proprioception and small fibers. You see, large myelinated fibers carry proprioceptive function where you do not feel whether the chapel is there or not. Whereas heat and cold is by the small sensory fibers. So it's a mixed large fiber, small fiber and motor fiber. So apparently with this involvement, the weakness is not at the level of the muscle, it is at the level of the nerve. If it is muscle, only motor will be affected. Sensations will not be affected. Here you are having both the proprioceptive sensation and the small fiber sensation is affected. So whatever caused the gripness is at the level of the nerve rather than at the level of muscle or anything. Because I know you are small children, you are presenting very well. If you have any difficulty in understanding me, I am trying to simplify. Any difficulty, you just stop me and ask me. Okay. Any difficulty? Am I clear so far?
Yes,
I am deriving it is a peripheral nerve. You understood, no? When it is
yes,
sensory, motor, it is always nerve or root or tract. If it is purely motor, it can be motor nerves, it can be muscles, it can be myoneural junctions or corticospinal tract. Whereas if it is sensory and motor, it has to be a peripheral nerve, never a muscle. Or it can be a root where it can have a mixed picture. Or it can be a spinal cord disease where sensory tracts and the motor tracts are degenerate, like that. So here it is a lower motor neuron with sensory and motor affection, so peripheral nerve that is affected. So at this point, unable to feel pain. So you have clearly picked up a beautiful symptom analysis. She is having no tingling sensation, no burning sensation. What does that indicate?
Negative symptoms are present, positive symptoms are absent of sensations.
She is only having negative sensory symptoms.
Yes, ma'am.
She is not having any positive sensory symptoms. That's a very important point. You see, positive is paresthesia, tingling. Dysesthesia, that is when you touch the floor, you feel it is some mud is there or some cotton wool is there. That is all positive sensory symptoms. Paresthesia, dysesthesia, hyperalgesia, they are all positive sensory symptoms. Positive sensory symptoms indicate generally an acquired condition. Because in acquired condition, there is disproportionate involvements. Large fibers always inhibit the small fibers. So when the large fiber inhibition on the small fiber is not there, then you get a tingling sensation. Whereas small fiber repair, you see one fiber is destroyed, so neighboring fiber is trying to repair that. But neighboring fiber is having different kind of quality. For example, when there is an outbreak of cholera in one rural medical college where I worked, cholera duty will be put for the neurologist, cardiologist, everybody. No? That means you are trying to help the gastroenterologist to manage an outbreak. Like that, when the nerve is destroyed in large fiber, small fiber is trying to repair. Then what happens? You touch the feet, patient will feel burning. Because a neurologist in the cholera ward will be worried about the fliliness of the muscles, electrolyte imbalance producing disorientation, the hyponatremia, hypokalemia, all those things the neurologist will concentrate rather than on the diarrhea. Whereas a cardiologist will see the pulse rate is falling, BP is falling, that they will look. Whereas gastroenterologist only will address the real problem. So it is depending on that. So when the small fiber is trying to repair the large fiber, small fiber is carrying pain and temperature, cold and temperature. So you touch, it will say it is cold or it is burning. That means repair is taking place. So in acquired neuropathies, there is dysregulation and repair. Whereas in inherited neuropathies, it is uniform loss. So positive features are absent from the beginning. At the end stage, positive features will not be there in any disease. But in the early stage itself, if there are no tingling sensation, no burning paresthesia, no dysesthesia, that indicates probably my patient's peripheral nerve involvement is an inherited condition. Understood? So one is the presence of a family history, will say it is inherited. Then multi-axial involvement, which is not contiguous, will favor an inherited condition with a fitting into classical inherited lower motor disorders, and absence of positive features indicate an inherited condition. So with this wonderful history that you have taken, this means that my patient has got a problem which is involving the cerebellum and the peripheral nerve, and probably it is an inherited condition. So this much information you can get from 2 symptoms. So that is because you have provided very beautiful history. Very nice history you have provided. That is excellent. So there is a multi-axial disease involving the paleo-cerebellum probably and the peripheral. Next. So next symptom, slow and slurred speech. So,
Yes.
so you think there is a scanning speech.
Yes, ma'am.
Slurred is the term you use when the speech is not having any specific character. You are not able to fit it into that. If the slow speech means, is he splitting the syllables or is he monotonous? Slow monotonous speech is a speech without any undulation, no music. That is dull, is we, oh, I am sitting in a cloth, like that. That is a monotonous speech that is seen in basal ganglia. Whereas if you have only splitting, that is scanning. That's a cerebellar speech. Slow speech means monotonous speech, low voice volume, unmodulated, that is extrapyramidal. So we will see what it is if when we examine the patient. So slow, we use the term slow monotonous speech for a basal ganglia disorder. Whether you speak slowly, your word output is very less, your voice volume is very less, there is no undulation, that is a monotonous speech of basal ganglia. So whether this is patient's own words, correct or wrong, we will try to do. Whether then additional structure is getting involved or not, we will see later. Okay. Then patient felt that there was an undue separation. So that's a different thing. That's a very clear scanning speech. Undue separation is a scanning speech, but slow speech is usually a word used to describe basal ganglia. Whether it is there or not, we will see. Okay. No thinking of that, no comprehension planes are not affected. So, okay. So there is a scanning speech is very clear. So from the paleocerebellum, now slowly the pathology is moving to neocerebellum. Whether basal ganglia is involved or not, we will just keep it like that and we will analyze at the end. So no nasal regurgitation. Okay. Then what else go on then? Slowness in initiating, continuing all the movements for 4 months. You see, in this there are 2 things. You said it is bradykinesia, no? You
Yes,
said it is bradykinesia when it is involuntary. Patient is unable to increase the speed, even though he wants to walk faster. She is a lady, she wants to walk faster than her colleagues, but she is unable to walk. She is slow. She doesn't know why. That is bradykinesia. Fixed distance walking time is more. To cover a particular distance or to carry out an activity, the time consumed is more, even though the person wants to be faster. That is bradykinesia. Whereas in cerebellar disease, when you reduce the speed of the movement, the stability will come. So patient will voluntarily reduce the speed. See, when you do quickly finger nose test, patient will show all the incoordination. That's why cerebellum testing, we tell, do faster, do faster. When they increase the speed, the clumsiness will become more obvious. But if they slowly do, the finger nose incoordination will not be seen. So to improve the quality of the movement, patient might voluntarily slow it. Then it is only cerebellar. Because already patient is having cerebellar quality in the gait, in the upper limb, in the speech, everywhere it is there. So voluntarily they will slow down. They will say, if I do fast, I do wrong. If I run fast, I fall. If I carry out my food very fast, the food drops. So I will do it slowly. That is a compensatory strategy to correct errors in a cerebellar disease. Is it so? Then it is voluntary. If the patient says, no, I am unable to increase my speed, I don't mind my swaying or clumsiness, then it is extrapyramidal. So then you use the term bradykinesia. Bradykinesia is involuntary. Patient wants to be faster, but he cannot. That is bradykinesia. Whereas in cerebellar patients, they will voluntarily slow down so that the quality improves. They don't sway much, they don't fall down, they don't spill their food. So that elaboration is needed. They will not know. Subconscious mind, they become slow, so they are more steady. When they are very fast, they tend to sway and fall. So they slow it down. Then they'll say, I don't know, I am slow. What happened, I don't know. Then you ask them, if you move fast, can you move? Yes, I can move fast, but then I fall down. Then it is cerebellar. If they say, no, madam, even though I sometimes try to move fast, I am unable to move fast, then it is bradykinesia. So that's the difference. So we will keep it, whether the basal ganglia is involved or not, we will keep it as a question mark. No? Okay, next. So nothing. Oh, these are the features. No? So mainly at this point, it is pan-cerebellar plus peripheral. And probably it is inherited. Because one thing you showed a family history, and it is positive sensory features are absent. So it looks like a recessively inherited condition involving pan-cerebellum and the peripheral nerves.
Mom, actually, the father died around the age of 50, so we can't tell because if the age of onset would be around that for the father to elicit.
Mother is there, huh?
Yes.
So then there is many members are affected. So you think whether dominant cannot be ruled out, may be correct. Whether it is a dominant, we do not know. If the father died very early, that part is correct. But many siblings are affected and parents apparently normal as per the family tree. So I thought it is autosomal recessive. But if the father had died, you can say we do not know the pattern of inheritance because one of the parent died very early. Whether he had any disease, we don't. So either way, you can keep it like that. Okay. What is pseudo-dominant? You heard of pseudo-dominance? No need. Supposing a carrier marries a patient. A patient is suffering from a recessive disease and that person marries a carrier. Then it will look like a dominant disease. That is called pseudo-dominance. Because disease patient has both alleles disease and the carrier has got one allele disease. So both join for the babies means it will look like a vertical transmission. That is called pseudo-dominance. Doesn't matter, just for interest I do. Okay, so good. So it looks like a inherited disease. Dominant or recessive, will keep the question because one parent died early and it is involving both the cerebellum and the lower peripheral nerves. Whether basal ganglia is involved, we do not know. So that is the differential diagnosis. So you have to consider diseases which involve cerebellum and the peripheral nerves. That will be the differential diagnosis. That part elaborately, as an undergraduate, you need not go into the diagnosis of that. If you describe itself is sufficient. But at the end of the history, it is an inherited disease involving both the pan-cerebellar plus peripheral nerve plus minus basal ganglia. On examination, you go to examine.
Examination, the informed consent was taken. Examination was done in a well-lit room and patient was sitting comfortably in bed. Patient was conscious, cooperative, obeying commands and oriented to time, place and person. She was moderately built and well nourished. BMI was 27.2 kilogram per meter square. Obesity class 1 according to WHO for Southeast Asian countries. The vitals were normal. General physical examination. Um, Nothing significant was seen. On the inward
In
bending of
patient with the cerebellar thing, grossly, what you will have to look in a general examination? Yes, as a undergraduate girl, that is what you have to learn. Too tall or too short. Then are they having any features of, you mentioned all those things, I think, like Wilson's disease, hyperparathyroidism, cerebrotendinous xanthomatosis. You see, there's a peripheral nerve involvement. So you should specifically look for tendon xanthomas. So cerebellar involvement, basal ganglia involvement, and tendon xanthoma, you see, means the diagnosis becomes straightforward. Cerebrotendinous xanthomatosis. It manifests usually much younger, but it can manifest late also. So you have to look for tendon xanthomas. Then you have to look for KF ring. You have to look for cataract. Then you have to look for skeletal abnormalities, intellectual abnormality, pingukula, arteriovenous malformation, telangiectasia. So hair changes, any neurofibromatosis, K-Fiole spots. All this will give some clue to the diagnosis. So in the general examination, too tall means if they are this Klinefelter syndrome, they have prone for cerebellar degeneration. No? And too short, Down syndrome, they are prone for craniovertebral junction anomaly where the cerebellar tonsil come down so they can present the cerebellar signs. So Down syndrome. So Down syndrome, Klinefelter syndrome, achondroplasias, they all can present the ataxia. That's a too tall, too short. No? Then this cataract hypoparathyroidism, KF ring Wilson's disease, then telangiectasia. So you have got conditions with telangiectasia and the cerebellum. That and all, I am not expecting you to tell the syndromes. Retinal hemangiomas, conjunctival hemangiomas, with cerebellar hemangiomas. Then you have got the small iris or absent iris. That goes with the conditions which involve the cerebellum, kidneys, and aneurysms in the circular villi. So in the eyes, telangiectasia, KF ring, you should not forget. Then iris, cataract, fundus abnormalities, no? Then skin neurofibromatosis, K-Fiole spots, xeroderma pigmentosa, that is dry scaly skin. Then some tendon xanthomas. So these are grossly in the general examinations. You have to examine in a cerebellar patient. Okay, then.
Nervous system examination. She was a right-handed person, educated till 10th class, and she can understand, speak, read, and write in Hindi. The higher mental functions, the patient is conscious and oriented to time, place, and person. The Glasgow scale was 15 on 15. Immediate, recent, and remote memory are intact. Intelligence is intact. Concentration and calculation is intact. The speech is slow, having multiple pauses in between. Scanning type of speech. Repetition is intact. Reading and writing are intact. Naming objects and phonation is intact. No aphasia is seen. Progressive micrographia was present on writing. Apraxia, hemi-neglect, hallucinations, and delusions are absent.
So micrographia you see in what condition?
Bradykinesia.
So if it is a mild extrapyramidal involvement only. So cerebellum produce macrographia. Cerebellum will make the letters big. So indicates an element of extrapyramidal involvement is probably there. Then what? Go on.
Examination was normal except for loss of fast saccadic eye movement. There were hypometric saccades present, and she wasn't able to fix her gaze at one point for more than 30 seconds, and she used to move her gaze horizontally.
So she has fast saccades, slow saccades. So she's saying slow saccades.
Yes, ma'am. Means when I was doing the H test, then it was taking her time to reach the point where I was putting my
But
finger.
she can generate saccades, no? She's able to generate saccades, but they are slow saccades. Agreed.
Yes.
Agreed. Then
other all cranial nerves.
Patient with the peripheral nerve involvement as well as this eye movement abnormality, and you do not know the pattern of inheritance, it is manifesting little late. Then one is, supposing it's a Friedreich's ataxia, not at all in this case, it will manifest very young, but the eye signs will help. Square wave jerks. So it will be square wave jerks in Friedreich's ataxia. Whereas slow saccades in spinocerebellar ataxia 2. Supposing it is spinal cerebellar ataxia 3, these are the ones which lot of eye movements are shown. If that will be a saccadic pursuit, that means you tell the patient to watch a slowly moving object. Here what you elicit saccade by watching fast movements. You tell the patient to look at two targets, generate fast movements. They are not able to generate fast movements, but generate slow saccades. That is what you are telling. That is seen in SEA2. That's a very important clue. But you tell the person to slowly follow a movement. That's a pursuit movement. The pursuit is not there. Instead of this pursuit, they develop multiple saccades. That is called saccadic pursuit. I am understanding it may be a little tough for an undergraduate, but you seem to be a postgraduate standard presentation. So I'm telling you. So saccadic pursuit is SEA3. Square wave jerk is Friedreich's ataxia, whereas slow saccade is SEA2. So if you do not know the pattern of inheritance and the patient has slow saccade and the disease is manifesting in this decade, it will probably indicate a SEA2 type condition. Is one possibility. The eye signs is a clue. I am just telling the eye signs. Supposing you have got up gaze palsy, down gaze palsy, horizontal gaze palsy in a patient with extrapyramidal, that will point to some group of disorders. But in this patient, the extrapyramidal is not dominant. So cerebellum is dominant. So we'll just keep it. Just I am telling you a point to think about. Okay, next.
Then motor function. The attitude of upper limbs was normal. The attitude of lower limbs was paraplegic, paraparetic. It is bilateral lower limbs were extended at the hip and knee and externally rotated at the hip. The foot was inverted and it was having a foot drop.
So severe
Then
lower motor involvement.
yes, ma'am.
Severely lower motor, no?
Yes,
What is the tone like?
Hypotonic.
Okay.
Then muscle bulk, it was normal throughout except for in the calf muscles, which was on the left side 29 centimeters and on the right 27 centimeters. Then lower limb hypotonia was present, upper limb tone was normal. The muscle power on the right side in the hip and the knee muscles was 3/5, left was 4-, and around the ankle on the right it was 2/5 and left it was 3/5.
Okay, so distal weaker than proximal.
Yes. Then superficial reflexes, plantar reflex, dorsiflexion was present, and superficial abdominal reflex was present. Then deep tendon reflexes, the upper limb reflexes were normal. The patellar reflex, it was hyporeflexic. But when it was elicited by the maneuver, then pendular knee jerk was present. And ankle jerk was also hyporeflexic.
Okay.
Then in sensory examination, in all the crude touch, fine touch, vibration, pain, temperature and pressure sensation were reduced in the right and lower limbs equally, that is by 50% as compared to the upper limbs.
Okay.
Then coordination and cerebellar function. I don't think that I did it right because finger nose test was coming out to be normal and dysdiadochokinesia was also absent according to me.
Okay.
And heel to shin test and gait couldn't be performed because the power was less. Nystagmus was
Apparently, the gait started with cerebellum and now the speech is showing cerebellum. These are
yes.
the things you are able to demonstrate. And now you cannot demonstrate the gait. Agreed.
Nystagmus was absent. Romberg's test couldn't be assessed. Rebound phenomenon was present in the lower limbs and titubation was absent.
Okay. Legs are weak, but you could demonstrate rebound.
Yes.
Okay. Then?
This you're told to get a video of normal person
We
walking.
just know this is the patient.
No, mom, this is not the patient. This is a normal person.
Okay. So I
Walk forward,
want the gait of a normal
turn,
person.
move back,
Just
move forward. You don't want this?
No, I wanted the video of the patient so that we
Oh,
can
walk
directly
forward.
assess that.
That is not present.
So patient's case only I just told him so that we can try to describe that. So now we have no mild extrapyramidal like micrographia. Is it a progressive smallness of the letters?
Yes, ma'am, it was progressive smallness.
You are the handwriting sample? No?
No, ma'am.
Okay. So if that sample was there, that would have been useful. So now there is cerebellar involvement in the form of speech abnormality, and predominantly it is lower motor neuron, apparently, from the examination findings. Because patient is bedridden and you are not able to demonstrate many signs. Agreed. Some rebound also you said. And micrography indicates probably some degree of extrapyramidal. So with involvement of the eye signs, saccadic slowing, severe involvement of the peripheral nerve. So you have to think of all the cerebellar conditions which involve the peripheral nerves in addition with depressed reflexes. That will be the differential diagnosis. We will ignore the pattern of inheritance because we do not know whether it is
Yes.
recessive or dominant, we do not know. So you have to give allowance to the peripheral nerve involvement. So that is, you can just enumerate the conditions where reflexes become depressed or absent in a patient with ataxia. You have taken out, okay. Ataxia, large fiber neuropathy. Dystonia is not there, no?
Oh, ma'am, that inward bending of the foot, I thought it would be
But it is a
dystonia.
flail foot with a foot drop, you said, no? You see, you call it
Yes.
a dystonia if there is a twisting. Twisting
Okay.
and increased tone. So
Okay.
dystonia is a person who is having a altered tone with a twisting. That is not there, no? It's a flail
Oh,
foot drop. That's what
yes.
you told, I thought so. You didn't tell
Yes.
me a limb with an increased tone, rigidity, with a
Ma'am.
continuous twisting movement. So dystonia is not there.
Okay.
That's why I just wanted to see the video of the patient, not a normal person. Normal person we don't know. So that I can tell, because you will be just getting exposed to neurology, you may not be able to differentiate all these things. So increased tone, which is altered with continuous twisting, that is dystonia. That is not there. It is inversion due to asymmetry in the power to start with. That's what we discussed. So Parkinsonism, you cannot call it. Parkinsonism means trap, tremor, rigidity, ataxia, partial abnormality. So unless all these are there, you cannot call it as Parkinsonism. You have some micrographia, but I am not getting the sample here. So it's a very soft sign for extrapyramidal involvement.
Okay.
Dominant feature is a peripheral nerve. And
Okay.
subtle features from the history and some findings is cerebellar. Autosomal dominant, we don't know. So we don't know, no.
Yes, ma'am.
We cannot commit it for the gene pattern. So you have to put correct, no? So
Okay.
you don't know. So nuclear gene encoder mitochondrial cells, some nuclear. So spinal cerebral, PKN, ataxia, Parkinson's, neuropathy, dystonia. Wilson's disease also Wilson's. So Wilson's and all you will not consider at all, because Wilson's you do not get a peripheral neuropathy. You can get muscle wasting. That is called Asian Wilson. Look, when there is a renal osteodystrophy secondary to increase excretion of proline and hydroxyproline, which happens in Wilson's disease, renal Wilson's. There you get a muscle weakness, you don't get a nerve. Storage disorders, okay. So go on, let me see what so what did you finally decide? I do not agree with dystonia, Parkinsonism, autosomal dominant, all those things I do not agree. Peripheral neuropathy, not large fiber, it's a mixed. You only said no pain and temperature.
Yes.
So peripheral neuropathy is motor, small sensory, large sensory, everything. So it's a distal,
Yes.
symmetrical, mixed peripheral neuropathy plus moderate cerebellar signs and almost very negligible extrapyramidal involvement. So here you have to consider patients who present with cerebellar signs and depressed reflex. That is what you forget about the pattern of inheritance. It's definitely inherited, but we do not know the pattern. It may be recessive, it may be dominant. So depressed tendon jugs, that is what I will take as a important clue. So common one, Friedreich's, but it is not Friedreich's because age of onset, skeletal abnormality, all those things are not there. Eye signs are different. So it is not Friedreich's. So non-Friedreich's type of conditions which present with significant peripheral neuropathy. One, you have got a vitamin E deficiency, Bason's convicts, A-beta lipoproteinemia, no? Rousey-Levy syndrome, Ruffson's disease. No? All these you can consider. And as I said, cerebrotendinous xanthomatosis, where extrapyramidal can also get involved. Then you have got conditions like Joseph-Mercado disease. Then some types of SCA4, if you know the pattern. So these are the ones which produce predominant peripheral nerve involvement. So peripheral neuropathy is the dominant feature in this case. Others are only history, and you are demonstrating a dysarthria of cerebellar type, a doubtful rebound phenomena in the lower limbs, and a micrographia. So they all become back. So dominant peripheral nerve. So it is not Friedreich's because the age of onset is, and other skeletal features are not supportive. So is it vitamin E responsive? Is it Bason-Convict? Is it Ruffson? Is it Rousey-Levy? These begin. There is a classification called Sid-Gillman classification. That is ataxia with depressed tendon jugs. These kind of situations where the tendon jugs are depressed. So that classification is Sid-Gillman classification. That is ataxia with retained tendon jugs, ataxia with increased tendon jugs, ataxia with decreased tendon jugs. That is a clinical classification. So some type of spinocerebellar ataxia, then conditions like Joseph-Mercado. Then if you take cerebellum and basal ganglia multisystem atrophies, you have to consider. There the peripheral nerve like pattern is autonomic, not mixed. So now you are not able to examine because she cannot stand, you cannot do the bladder is not involved. So it is not multisystem atrophy. But forget about the diagnosis. From your point, you have to pick up the structures involved. That is enough. So predominant structure involved is not is a peripheral nerve. Distal symmetrical mixed sensory motor peripheral nerve plus some cerebellar, some extrapyramidal. So you can just, and it is definitely inherited disease. So you can, I don't think that you will have to apply Sid-Gillman classification or genetic classification, anything like that. If you say it's a predominantly peripheral nerve disease, which shows a genetic pattern, whether it's autosomal dominant or recessive, I cannot say because the father died early, no? So many conditions which can be associated subtle cerebellar, subtle extrapyramidal, I will think about and evaluate. That is sufficient. And for your sake, when there is a cerebellar, what all general examination you will do? So as I told, Kefiales part, neurofibroma, tendon xanthomas, telangiectasia, KF ring, no? Cataract. So these things you should know so that you get all the points. Then you can refer your literature. When you become an MD student, you will make more diagnosis. You become a focused neurologist, you will become more diagnosis. That is sufficient. So that is a wonderful presentation. Very nice. Wish you all good luck. Any doubts you can ask me. For your level, localization, you have done excellent history. You have picked up the findings. But when you came to the diagnosis, we always say hard signs, soft signs, odd signs. Hard signs is the most dominant presentation. So you should always make your diagnosis on the hard sign. So in this patient, the hard sign is she is almost bedridden with peripheral neuropathy. She is not appreciating anything. So that is the primary sign. Symptom was different. Symptom you take with a pinch of salt only because patient is telling the symptom, what she thought and what we understood is all different. So hardest feature is a peripheral nerve. So that you should learn to pick up. never make a diagnosis on a soft sign. So in her case, the softest sign is a micrographia. And she will be slow due to multi-axial involvement. That slowness is not bradykinesia. And some cerebellar. So mainly hardest feature is peripheral nerve. So peripheral nerve plus. So this is a peripheral nerve plus syndrome. So take the peripheral nerve and fix it with the cerebellum. Extrapyramidal, I will give very less allowance. I will keep it there. You see? So like that. So you should put your features together and pick up the hard signs and make a diagnosis on the hard sign. If you have an odd sign, in this patient, if there is a tendon xanthoma, that becomes an odd sign. It's a clear diagnosis. So that can produce peripheral nerve, it can produce cerebellum, it can produce basal ganglia, it can produce dementia, it can produce fractures, many things. So look for odd features which will help you to clinch rare diagnosis. If odd features are not there, always make diagnosis on the hardest feature that is presenting to you. That much you learn. Don't try to go into the complexity of ataxias and neuropathies that you can slowly do later. So you have done a very wonderful history and you have done a wonderful examination. I would like to have confirmed all those things if you had the videos. That's okay, no problem. But capturing the hard, soft and odd, that will come slowly only. I just told you to how to put it into the template. Learn to capture the hardest features and fit the soft signs inside. Soft signs will go into many diseases. Hard signs clinch the diagnosis. So this is a peripheral nerve plus syndrome. So it is Siddgillman's depressed tendon jerks with cerebellar involved. That group it will go clinically. So that is good. Anything you want me to do? I want you to be strong only at this level. That is enough. No? Because you are
Yes.
already in the postgraduate level only. That is nice. So God bless you. Anything I want to ask me?
No, ma'am.
Wonderful, wonderful. God bless you. Thank you.
Thank you. Thank you so much.
Thank you. So we'll close.
I think ma'am left.